Thank you, Mike. Next up, Hilary Wall and Warren Jones are going to have a keynote conversation about solving barriers to SMBP. Hilary is a senior scientist in the Division for Heart Disease and Stroke Prevention at CDC. She serves as the lead scientist for Million Hearts, and she's the lead author of the recent Journal of Hypertension article titled, How Do We Jumpstart Self-Measured Blood Pressure Monitoring in the United States? Dr. Jones has headed TRICARE worldwide and Medicaid in the state of Mississippi. He has been a barrier breaker throughout his career. For example, he was the first African American elected as president of the American Academy of Family Physicians and to be appointed Associate Vice Chancellor of the University of Mississippi Medical Center. I'm proud that he is chair of the National Forum. Dr. Jones?
Thank you, John, and good afternoon, everyone. As chair of the board for the National Forum for Heart Disease and Stroke Prevention, it's my pleasure again to say good afternoon, Hilary, and thank you so much for joining us for this important conversation.
Thanks so much, Warren. I'm thrilled to be here with you today.
So Hilary, you're the first author on a recent publication in the American Journal of Hypertension entitled, How Do We Jumpstart Self-Measured Blood Pressure Monitoring in the United States, Addressing Barriers Beyond the Published Literature. Please share with us, why did you write this excellent article?
Thanks, Warren. The answer is simple, unfortunately. We have a hypertension problem in this country. I don't know if you knew that. If we go to the first slide, you can see that almost 1 in every 2 adults has hypertension. 1 in 2, that's almost 50% of adults. That equates to over 100 million people in our country. And among people with stage 2 hypertension and those who are high-risk individuals with stage 1 hypertension, 71% do not have their blood pressure controlled. What that means is 61 million adults are floating out there, working, caring for their families. They're all at increased risk for heart attacks, strokes, kidney disease, heart failure, dementia later in life, and multiple other sequelae. So one strategy that can help reduce blood pressure and improve control is self-measured blood pressure monitoring, or SMBP, which is likely what I will refer to it as. So I've been working on SMBP implementation for over a decade with a variety of tremendous collaborators from different federal agencies and organizations. And as we've tried to implement SMBP, we've come across a number of barriers that wouldn't necessarily be captured by a randomized controlled trial or some qualitative studies, like sort of outside of the published literature, if you will. So we wanted to call attention to those barriers and offer some potential solutions. And it's what we've learned as we've tried to translate science to practice. That's why we wrote the article.
Oh, great. So critically important. So what is self-measured blood pressure monitoring, and when is it indicated?
Yes, great question. We can go to the next slide. You'll see that self-measured blood pressure monitoring is the measurement of blood pressure by a person outside of a clinical setting, including at home. And ideally, it would be done with a clinically validated automatic upper arm device. Often SMBP is referred to as home blood pressure monitoring, but many of us who work in the field really prefer the term self-measured blood pressure monitoring. For me, it puts the emphasis on the patient with hypertension, and it allows for the patient to take their blood pressure where they're most comfortable. Could very well be at home, could be at work, while they're traveling. We want to sort of allow for all scenarios. And just to be clear, when I talk about self-measured blood pressure monitoring, I'm not referring to blood pressure that's taken at a pharmacy or grocery kiosk, or any of the sort of newer technologies that are, I feel like, emerging exponentially as we speak. Things like wearable sensors or cuffless blood pressure monitors. You and I may come back together in 3, 4, 5 years, and that may be exactly the topic that we're talking about. But right now, those are not rigorously validated methods of blood pressure measurement. So I'm not going to talk about those. And it's worth noting that when combined with additional support, SMBP is an evidence-based strategy for lowering blood pressure and improving control among people with hypertension. And it's also recommended for confirming new diagnoses of hypertension.
That's important. You know, as I listen to you describe that, I think about the emphasis right now on patient and family-centered care. And that is getting patients to buy in and participate in their management and have a good idea of how they can improve themselves. It seems as though this would be a useful tool. So is SMBP currently in use widespread in the US?
Well, that answer is a little bit complicated. You can see on this next slide, we don't have great data to inform this question. There have been, when we look at the published literature, there have been a few smaller cohort studies in some specific geographic and other populations that show about a 40 to 50% prevalence of SMBP use at home, right? This is, they're defined, SMBP is defined a little differently and as the studies vary. There are also two analyses using data from the nationally representative National Health and Nutrition Examination Survey, or NHANES. And the estimates we see from those two studies are pretty much in that same range of 40 to 50% of people who use SMBP at least monthly. And then more recent publication using data from 20 states and the District of Columbia from the Behavioral Risk Factor Surveillance System that reports prevalence among those with self-reported hypertension that looks, it's about 61% prevalence. And there's a small subset of that group that report sharing their readings with their clinical team via remote methods. Okay, and that's going to be important moving forward. But due to heterogeneity in how SMBP is assessed, so that includes how it's defined, how frequently people engage in it, and whether or not those readings are transmitted remotely, it's really challenging to fully quantify the current use of what I refer to as optimal SMBP.
I think that's critically important. So you just used the term optimal SMBP. What do you mean by that?
Yeah, great question. Next slide. This is my depiction of that optimal SMBP, where a patient with hypertension works with their clinical team to learn how to select a validated device with a properly sized cuff. They're taught proper preparation and positioning to yield the most accurate readings, and they're given a clinical protocol with frequency and duration for gathering readings, as well as a method for ideally remotely returning patient-generated blood pressure values. The clinical team then receives those values, they interpret them, and then they send back titration and or lifestyle modification advice. And to me, it's really this sort of remote data exchange via this patient-clinician feedback loop that is both the secret sauce of SMBP and its biggest barrier, frankly.
I find that very informative. So you mentioned earlier that there are many organizations that are concerned with working with SMBP implementation. Can you share some of those with us, please?
Absolutely. So there are a whole host of national organizations and federal agencies that are really what I would call champions of SMBP. And we all often work collaboratively to solve challenges, including obviously CDC and Million Hearts, but also the American Medical Association, the National Association of Community Health Centers, the American Heart Association, HRSA, and the Office of Minority Health from the Department of Health and Human Services, the Surgeon General's Office, and many, many others that are not listed on this slide. So for example, the National Association of Chronic Disease Directors and state and local departments of health, they've been playing a huge role in implementation for a number of years. We also have a group called the Federal Hypertension Control Leadership Council that is a leadership level group of representatives from most agencies within the Department of Health and Human Services, and SMBP is a primary focus for them. We also have the Preeclampsia Foundation and just so many others. I could go on, but what I love is that, I said I've been working on SMBP for about a decade, and we've seen more and more and more organizations coming to the table, raising their hand saying, how can I help with this, which is really wonderful.
It's amazing how much work you've been able to do in that decade. You must have started as a teenager. But in your opinion, why has the US been unable to achieve widespread implementation?
Yeah, and this is really the crux of the issue. I think because optimal SMBP relies on technology and has both that patient-centered component and a clinician-centered component, I think that makes implementation really complicated, right? You've got like different groups of people, you've got technology trying to connect them, so it's complicated. Some of the barriers that we've encountered include the need for simplified, standards-based, interoperable health information technology that can robustly support that remote exchange of patient-generated blood pressure readings that I mentioned. If we are able to figure that whole data transmission pathway out, it really relies on the ability to have ready access to high-speed broadband or high-speed internet. And then if we do have access to high-speed internet, there are many patients who are not internet savvy. So they may actually need help to overcome the digital divide. Once we get some of those technology issues taken care of, we really need an ample supply of validated blood pressure devices with appropriately sized cuffs. This is such a key point. And to support all of those efforts, we need improved coverage and reimbursement, coverage for blood pressure devices, reimbursement for clinical services to educate patients and interpret their readings. And then lastly, we need sort of creative solutions or out of the box thinking to overcome barriers of trust, time, distance. To me, this is like, how do we really bring SMBP to the masses? So those are some of the challenges that we have identified.
As you know, I live here in Mississippi, and we have significant deserts, if you will, for high-speed internet. So I could see that being a problem. But I was wondering, why are technical standards important?
Yeah, this is a great question that we could get really into the weeds in as I answer it, but I won't. So, you know, when people think about taking their blood pressure at home and getting those values to their clinician, I think we all, if you're not like really into informatics, you might think it's pretty simple and straightforward to get those values to your clinician. You know, person takes their blood pressure at home, maybe the data kind of go into an app on their smartphone or their computer, and then that app just sort of magically sends them to their clinician's electronic health record. But I can tell you what you're seeing on the map, on the screen, excuse me, is actually more what the health IT and informatics landscape looks like for SMBP. It's complicated. There are a number of different pathways through which patient data can currently travel, and often clinical entities must pay for sort of customized solutions with various intermediaries so that they can receive patient data and interface with the electronic health record. So basically, like where you see all the yellow arrows on this this slide, that's where many of us think we could have some simplification. And technical standards are one way to address what we call interoperability, which is really just devices' abilities to talk with one another. Right now, we don't have great interoperability in this part of the spectrum, right? When it comes to this patient-generated data getting into electronic health records. So implementers often have lots of questions like, if I use electronic health record X, which SMBP device and which Android phone are best to use, you know, to make that all work? And that's really tough to answer. So if we had some technical standards that were used by all of these pertinent parties, then it wouldn't matter which electronic health record, which SMBP device, or which phone people used.
I see, and that's so critically important. We run into that with electronic health records also, as you know. Um,
Sure.
one practice's system doesn't talk to another practice's system.
Exactly.
And I was alluding to earlier about the broadband deserts. What do you see as a solution to the big challenge of getting access to broadband for patients that need it?
Yes. So let's hypothetically say that we're able to achieve that interoperability I just mentioned using standards and other means. Again, all of that relies on having access to robust high-speed internet. And when it comes to looking at broadband access, which in my opinion is a very important social determinant of health. I don't think it's been looked at like that for a long time, but people are really starting to understand this is something that folks need, and if they don't, it may impact their health. So there are issues related to both physical availability of broadband based on where you live, and also affordability. Can you actually purchase internet if it is available for you? And I just want to say this because people may be having this question. Satellite internet is technically available throughout the United States, but satellite internet is very expensive. So that is never my first answer when people say, how do we get broadband to people? It's sort of, the fourth or fifth answer. So I'd like to share a few maps with you that get at some of these issues. This first map looks at the gaps in physical broadband availability across the US, overlaid by self-reported hypertension prevalence. Where you see darker red, that means higher prevalence of hypertension. And the yellow outlines on this map show counties where more than 50% of the population cannot get high-speed internet because it isn't offered where they live. And you'll note there's a correlation between hypertension and lack of broadband access. Now, there are definitely a few additional nuances to really consider as we think about this topic. So let's say you can, in theory, get high-speed internet where you live. High-speed internet is defined, it can be defined in different ways. And so the Federal Communications Commission defines high-speed internet as 25 megabits per second download speed and 3 megabits per second upload speed. Really? But that is really like the bare bones of high-speed internet. And many of us who, if we work from home, if you've got more than one person at home using the internet, if you're doing higher level processes, that's not sufficient for high-speed internet. So we need to get to a higher level. And I am confident that the Biden administration's infrastructure plan, which carves out billions of dollars for broadband access, they are trying to raise that standard as well. And the other thing is, you pay for internet, say you pay for 110 high-speed internet, but there are some who suggest that the broadband gap in this country is even worse when you consider the broadband speeds and quality that are actually experienced versus allegedly available. So you pay for this speed, but we all know we've been on Zoom calls and they get dropped or the quality degrades. So when you average that all out, you may not actually be receiving that 110 speed. It may be a lower speed. And you can imagine in rural areas, for example, that probably happens more often than it would an urban area. And then the last nuance to really consider is, it's one thing to have broadband available to purchase, but if there's only one internet service provider where you live, there's no competition. So they can charge whatever they want. So that sort of bridges physical availability and cost. But we have included a map in the publication that you mentioned that looks at competition across the US and where broadband is available technically, but there aren't competitors to help drive the cost down. And so speaking of cost, on the next map that I'd like to share, this one looks at county level self-reported hypertension data again, overlaid by the percent of households that do not purchase a broadband subscription. So those are the yellow circles. Small yellow circles are 30 to 50% of the population. The larger yellow circles are greater than 50% of the population does not purchase a broadband subscription. And you can see, again, there's this correlation between those two aspects, self-reported hypertension and whether or not folks purchase a broadband subscription, with much of the yellow appearing in the stroke belt. You're in Mississippi. You started out by saying there are, broadband deserts, and that's exactly what this map shows. I'm in Georgia. The Georgia portion of this map shows the urban-rural divide that we have when it comes to internet. The northern part of the state of Georgia is Atlanta, the metro Atlanta area. We've got, people purchasing broadband. On our East Coast, that's Savannah. Those are our bigger cities. Folks purchase broadband, but much of the rest of the state that is more rural, people don't. So there are some federal programs that may help offset the cost of broadband service, but just to be honest, this continues to be a challenge. And then an added complexity that we all need to address is something that we've learned through our work with clinicians in the field. And to be honest with you, this was really not on my radar, but pretty much every clinical team we've talked to about SMBP has had to provide technical assistance in some form or another to patients to connect their SMBP device to their home internet, for example, download and use necessary applications, and transmit their blood pressure readings to the clinical team. Like, they've had to help them with that. So access to high-speed internet is the priority issue, but helping people to use it as well is not far behind, unfortunately.
Wow, that's an extremely complex waterfront of issues you just described that are so critically important. And I just want to go back to one thing you said earlier on when people talked about satellite opportunities for rural areas. People forget that with the weather changes that are going on, a very cloudy day, you will not get satellite high-speed internet access for very, very well. So your point is well made about the need to have a land-based internet access. Yeah.
Absolutely.
And I'm just excited to hear the things you're describing. So home blood pressure devices seem to be commonly available in pharmacies and on Amazon. So what are some of the challenges you see in the arena of making sure that the right kind of devices are available to the right people?
Yeah, so Warren, not all SMBP devices sold in the US are created equally, unfortunately. And if we move to our next slide, so to address this issue, the American Medical Association provided tremendous leadership, and they created the US Validated Device Listing, or VDL. And the VDL requires independent clinical validation of blood pressure devices, which goes above and beyond FDA approval for devices that are sold in the United States. And currently, there are 31 SMBP devices from 11 different manufacturers on the VDL, which is great. The information that's provided for each device is provided by the manufacturer, and it's fairly limited. Here's the device model, here are the cuff sizes that's available in, that kind of information. And then the National Association of Community Health Centers, again, to try to help with implementation, they've created an at-a-glance tool that provides useful contextual information like cost of devices, which is key, availability of an extra large cuff, and various technical aspects of all of the devices on the validated device listing. And CDC is actually helping them to update that tool quarterly. And as we're thinking about getting devices into the hands of people who need them the most, and frankly have the hardest time acquiring them, if we click on the next slide, it's really important to think about cuff size. So in the latest analysis that we have available, we know 52% of men and 38% of women in the US with hypertension require a size large or greater blood pressure cuff. And in the projects that we've actually done with the National Association of Community Health Centers to implement SMBP, more than 50% of participants needed extra large cuffs. Okay, so we need device manufacturers to have appropriately sized blood pressure cuffs readily available to match the needs of people with hypertension. And it's also super important that patients are told their numerical arm circumference value if they are expected to purchase their own device. This is because basically device manufacturers are at liberty to use their own size labels for their cuffs. So they can call anything they want. They don't have, there aren't, again, standards that they are required to follow. So if you look at the blue box on this slide, these are fairly standard measurements for in-office blood pressure cuffs, right? Where we see large accommodates arms that are 35 to 44 centimeters in circumference, extra large is 45 or greater. But if you look at some of the devices on the VDL, which I've listed at the bottom of the slide, when they label something as extra large, sometimes that correlates to those sizes I just mentioned, and sometimes it doesn't. So for example, you can see Omron, when they say they have an extra large cuff, It accommodates arms that are 42 to 50 centimeters in circumference. The Hiram Welsh Allen company, their extra large accommodates 40 to 54 centimeters. You would expect that. But an extra large cuff from TransTech accommodates 22 to 45 centimeters. And that's only 3 additional centimeters more than their large cuff. And then Care Simple, they offer something called an extended cuff. They don't have an extra large cuff, but they have an extended cuff. To me, that implies it may accommodate larger arms, right? But it actually stops at 42 centimeters, which doesn't even cover the typical spectrum of a large cuff. So we really need to be aware of those cuff size labels and ideally get some standardized definitions for what different cuff labels have to include.
As I listen to this and learn, I think we also need to, we may need to educate some clinicians' offices on how to make sure they've got optimal cuff sizes, because I need to share with you, very few offices that I've seen have 4 categories of cuff sizes. Okay,
Really?
basically a pediatric cuff, an adult cuff, and a thigh, a large cuff. And so it's amazing that we've got to educate my colleagues and me as well. So thank you for that. You mentioned insurance coverage earlier for SMBP devices. I guess that must be fairly good in the US now, right?
Well, you might think so, but what we're finding is that that is not necessarily the case, unfortunately. So let's go through a couple scenarios. Right now, fee-for-service Medicare does not cover blood pressure devices for people with hypertension. They do reimburse for what I'll call wraparound services like education and the clinical interpretation of values. They do reimburse for the services, but not for the devices themselves. And, you know, for our health center patients, which in many cases are our most vulnerable patients in the US, recently CDC partnered with the American Medical Association to conduct a comprehensive Medicaid analysis related to SMBP. And so you can see those results, the preliminary results on this slide. We published those in the manuscript, and overall, 33 states offer some level of coverage for SMBP devices. 21 states provide some level of reimbursement for those wraparound services. And that actually seems pretty good, right? I mean, 33 states offer coverage, but what you don't see when you look at a table like this is the level of funding that each state provides and whether it sufficiently covers the cost of purchasing a device. So unfortunately, the level of coverage and reimbursement does vary greatly. And if we can go to the next slide, the American Medical Association recently published a state-specific coverage summary using those data that we just saw in the previous slide. And this shows you just how disparate coverage can be, right? So if you look on the right under the blood pressure devices, you can see Alaska, they cover $110 for a device, which is quite good. But Arkansas covers $8.22. There is not a blood pressure device that you can get anywhere near that value. And you can see some of the states in yellow. To me, that's sort of the middle of the road coverage. You might get what you mean. You might be able to get a device that you need. You might not. You know, we can see DC has pretty good coverage. So what is really important to note that is if you have a patient that you would like to use an SMBP device from the VDL and they need an extra large cuff, you're looking at least $100 for a device that is validated, clinically validated, and can accommodate an extra large cuff. So, and I'll tell you, Warren, I'm sorry, but Mississippi Medicaid does not currently cover SMBP devices. So we have more room for improvement across the country.
After having been the executive director of Mississippi Medicaid, I'm not surprised. Okay, just so you know. Hilary, when it comes to SMBP implementation, it seems like we're putting additional burden on physicians and clinicians. Is that the case, or am I misinterpreting what I'm hearing?
So I can absolutely see why you would think that, but that's actually the opposite of our intention with SMBP implementation. We are hoping that, using SMBP frees up particularly the physician time to deal with the very complicated issues at in-person visits, right? If you've just got sort of a patient with non-complicated hypertension, many would say you might not need to see that person, or maybe you need to see them once a year. And SMBP can allow you to do that management outside of that in-person visit. And there are many parts of implementation that can be done by other persons other than a physician. So when we look at the next slide, this table outlines all the various tasks that are needed for SMBP. The first column are things that really must be done by a licensed clinician, right? Diagnosing hypertension, prescribing medications, et cetera. But they'd be doing most of those things anyway. Right. The third column, those are things that must be done by the patient, right? They need to take those medications. They need to take their own blood pressure. They have to make the lifestyle modification choices. But everything in that middle green column that you see, these things also need to be done, but there are things that don't have to be done by a physician, for example. Non-licensed staff, and frankly, I would argue that folks outside of a clinical setting could be used creatively to deliver these services. So what I mean by that is, if we look on the next slide, in a given healthcare setting, are there pharmacists or community health workers who can help support SMBP efforts? Can medical assistants take on some of the SMBP related tasks? I know in some health centers, there are AmeriCorps volunteers. Maybe they can be taught to do some of those tasks associated with SMBP. And then out in the community, there are some YMCAs that offer what they call their blood pressure self-monitoring program. That could be used to help educate patients and support efforts. There are maybe local departments of health that have public health nurses that could support SMBP efforts. You know, even groups like senior centers, fire stations, you know, we need to sort of think outside the box. They may have resources or staff that could be leveraged to support SMBP implementation, especially like in more rural areas. So I really think this is going to take many of us putting our brains together and thinking creatively about how we bring SMBP to the masses. And I will say the American Medical Association is working on an SMBP curriculum specifically for training community health workers on SMBP. And I think that will help immensely in this space.
I was glad to hear that, because I was going to ask about community health workers, because, you know, there's been such a tremendously positive impact from the promontories and other community health workers. So I was glad to hear that they're being brought to bear on this tremendous problem.
Absolutely.
What a waterfront of issues, but a great opportunity. What can National Forum members do to help?
Hopefully a lot. You know, so when I talk about SMBP, normally I either talk to like sort of a solidly public health audience or a very clinical audience. Those are my two groups of folks that I talk to about SMBP. But what I love about the National Forum is that, yeah, you've got folks in those two silos, but there are so many wonderful member organizations who have raised their hand to help address with cardiovascular health that are in, you know, that are just different types of organizations, right? Not necessarily public health, not necessarily clinicians. They sort of run the gamut. And so I think this really is a great opportunity for us to really put our heads together and think about how these organizations can help with SMBP. I personally would ask your members to think about their specific spheres of influence and how those might be leveraged to support some of the issues we've discussed today. I certainly have some ideas in that space, but I'm always happy to have discussions with folks to brainstorm further, because I really do think that this is an all hands on deck situation. So I've put my email on this slide. I would love it for any of the National Forum members to email me if they would like to help with SMBP, because we can definitely put our brains together. But a couple that I've come up with, definitely, if there are ways to support interoperability efforts, there's also some privacy and security concerns that I didn't get into, but really anything that they can do to help support patient-generated health data getting to clinicians. And this is a very rich discussion that could be had about all of that. Also supporting the use and ready availability of validated blood pressure devices and appropriately sized cuffs. The CDC, the federal government, and many of those other organizations I mentioned earlier, if we're talking about SMBP, you're going to hear us say validated devices. That's where we want to be driving the field to, patients to, clinicians to, and manufacturers. We want them to get their devices up on the VDL. So anything that we can all be doing to amplify that message would be very helpful. And then that whole community-based infrastructure for supporting SMBP implementation that I mentioned, I think there's probably lots that can be done in that space that, people who have a different perspective than I do might be able to come up with very ready solutions. So that's sort of ripe for help there. But at a minimum, if none of those things are sort of in your bailiwick, all of our organizations are employers. And many employers provide health insurance for their employees. So can you work with your organization to understand, do the health plans that you use cover SMBP devices for your employees or the wraparound services? If not, even if we could encourage more coverage in the private sector on those topics, like that's going to be a huge win for all of us. And to me, that's fairly low hanging fruit. So if everybody even just worked on that one item, you would make me very, very happy.
Great, Hilary, but I'm a little greedy. In addition to working on that, I'd like for them to make sure that they include SMBP education as a part of their benefits education process, because if they know that, and right now some plans will give you extra credits if you do certain things, and SMBP sounds like it would fit in there so nicely to help control problems with hypertension and help increase presenteeism. So I really love the ideas that you're offering for our members to be able to help. Ooh, this has been fun. But is there anything else that you'd like to share with our members as we come to a close?
Well, I have to imagine as the members, hear our conversation today, they're all going to be, chomping at the bit to help with SMBP. So for all of those folks, I did want to invite them to an SMBP forum that Million Hearts and the National Association of Community Health Centers hosts. It's basically like a quarterly community of practice, but it is open to anyone and everyone. And we actually have several hundred members who participate, and we bring on expert speakers, we share best practices, and we allow for members to ask questions of the group. There's a very robust chat that happens in the Zoom during these forums. So I would love it if folks would join that SMBP forum if they haven't already.
Wonderful idea. And I'm sure that our members will do that in large numbers. And again, Hilary, I want to thank you for being here today, especially because of the benefit of your article that's entitled, again, How Do We Jumpstart Self-Measured Blood Pressure Monitoring in the US, Addressing Those Barriers Beyond the Published Literature. That's an informative piece. Today, we've been blessed by having you expound upon that for us. So thank you so much for joining us today.
Well, thank you, Warren, because you have been just a wonderful host, and I really, really am very grateful for the opportunity. Thank you.
Have a good day, everyone. Thank you so much.